The broadcast is now starting. All attendees are in listen-only mode.
Hello everybody and welcome to tonight's webinar. I'm really pleased to introduce you to how to deliver effective opioid substitute treatment in prisons. My name's Kate Halliday and I work with SMMGP. So we're going to get a chance to have a look at overcoming organisational and cultural issues, stabilisation and assisted withdrawal, and retox. And I'd just like to thank our sponsors, Farm, who's given us an educational grant to run this webinar. So the format of the webinar is going to be, we've got three fantastic presenters who are each going to speak for around 15 minutes on each of these topics. And then we're going to have some time for questions at the end. A little bit of housekeeping. We are going to be recording this webinar tonight. So please be aware that you don't need to have the slide set because you can watch it again. We are going to give you a chance to ask some questions. And so there's a little chat box in the corner of your screen. So please do type your questions in there and I'll do my best to put them to the presenters at the end. We have quite a few of you watching tonight. So if we don't get round to your questions, we apologise. And also, if you have any problems in terms of technology, pop them into the chat box too. We'll do our best, but we cannot always help with that. Okay, with no further ado, I would like to start off by asking you a question. And so we are just going to give you a quick poll. So our first question is going to be, have you ever felt that the prison regime has constrained your ability to provide care that is equivalent to that in the community? So you should see that on your screen. Can you just click and start voting? Oh, I can see lots of you are voting. That's great. This is anonymous, so we won't be providing names to anyone. Okay, so we are going to close that now and we're going to show you the results. So as you can see, a whopping 63% of you have said that you do feel that the prison regime has constrained your ability to provide care that's equivalent. 6% of you have said no, but bearing in mind that 31% of you don't work in secure environments. So I would say the vast majority of you working in secure environments are feeling that the regime has constrained your ability to provide care. Okay, so we are going to move straight on to our first presentation. I'd like to introduce Dr. Bray, who's a clinical lead for drug and alcohol treatment in North East prisons for Spectrum CIC. He's going to talk about overcoming organisational and cultural issues. So over to you, Josh.
Thanks very much, Kate. Welcome, everybody. Good to have you.
Muted.
So the first thing to say is, who am I? Because you like to know where I'm coming from and what experience I've got. So first of all, I'm a doctor. I'm a substance misuse specialist doctor. I used to be a psychiatrist, and then I was a GP for a long time, and then I was a medical director of an inpatient detox and rehab drug and alcohol unit. So I've worked in virtually every substance misuse treatment setting that you can think of. And now I'm the clinical lead for substance misuse treatment in the 7 northeast prisons, which includes Durham, which is the busiest prison in England, apparently. It's now a remand prison for the whole of northeast. And there's a women's estate as well as the young offenders, and there's some local prisons as well. So it's quite a mixed bag for the 7 prisons, and it's pretty busy. So I've been doing that for the last 3.5 years or so. And I work for Spectrum Community Interest Company, which some of you may have heard of. So why are we talking about this a minute? It's basically because culture is very important, and how we work and the environment we work in is extremely important. It's all very well having guidelines and things, but actually when you come up against the real world and and difficulties, then it's good to have sort of thought about these a little bit. You can have strategy, of course, to try and overcome the culture, but the well-known saying is culture will eat strategy for breakfast, and that's true. If the culture of an institution or a place is very strong. We don't treat people in isolation in prisons. That's especially true in prisons. It's a sort of a closed system, and there's all sorts of things that can impair our effectiveness, and I think the poll has shown that, which is very interesting. There are conflicting organisational aims. The different people involved have different aims for their organisation. They want to achieve different things. That can be difficult, and there's always a legacy from the past. I don't know if you've ever started working in a place where you've taken over from someone or another organisation. There are always things from the past that are in there and that are very ingrained. And the mantra you'd hear quite a lot when you come in and try and do anything different is, well, it's different in prison. So especially if you come from the community to work in the prison, and you'll be told it's different in prison. So that's quite important to remember, and that's a culture to overcome. Now, hopefully, in a quick look through these issues, we'll be able to touch on things that are affecting all of us. And I thought there were 3 P's and 3 S's that we could talk about. The 3 P's are the place, the people, and the problems. And the 3 S's are some suggestions and solutions. I know that's a bit, that's fudging it a bit, but suggestions and solutions. So hopefully it'll be practical, and by the end we'll have a little bit more of a vision for the future and how we can improve treatment. So what about the place? Prison. Well, prison, what sort of place is prison in terms of substance misuse treatment? It's quite unique. Is it a home? Is it like treating someone in a home? Well, yes, it's the home, and they're there and they live there, but it's not the same. They haven't got the same things around them, same people around them, same opportunities, for better or for worse. And there are lots of things affecting their lives which are different. And they're also surrounded by a lot of other people with similar problems. So it's like their home, but it's not quite just a home. Is it like we're treating them in a community service? Well, yes, in a way. There are there are some workers, psychosocial workers and clinical workers, and that's great, and you can get appointments and see people. But it's in some ways it's almost better than a community service in some ways, in terms of access to treatment. But on the other hand, again, there are different pressures on people in prison and different issues that affect them that are slightly different from being in the community. And of course, they're not free to come and go. Is it like a residential detox or rehab? Well, in a way, because there are workers around and you get some intensive treatment. You can have alcohol detoxes and you can be monitored, and that's great. But it's got some other rules and regulations, and to be fair, there aren't the amount of people in the prison to do the monitoring and the care that there would be in a residential substance misuse setting. So it's like that, but it's not quite like that. And is it a hospital? Because there are nurses, aren't there? And in some prisons there are 24-hour nurses. Most aren't, but we have in Durham, we've got 24-hour nurses. But when there's only 1 or 2 nurses on for the whole prison overnight, it's not really like a hospital. So it's like it, but it isn't. It's got elements of all of those settings, but it's not the same as any one setting. So I suppose we could say prison is different. That leads us to, what about the equivalence of care? Is that the same as the same care? Well, no, I would say it's not, because it's a different setting, and there are all sorts of other issues that impinge on our treatment we can give, and a lot of us have experienced that. And so care should be equivalent, and that's what the guidelines say, but it's not the same. I would say sometimes we give better care in prisons. I would plug that, but it does have its challenges. So that was the place. What about the people? Well, there are all sorts of people who work in the prisons, aren't there, that we work with. So there's the prison staff, primary care staff, substance misuse clinical staff, if they're different from primary care staff, and substance misuse psychosocial staff, There's organisations in which we work. There's prisoners or stroke patients or clients, depending on what you like to call them, and then there's ourselves. So you see attitudes. You see attitudes in all these people that can be helpful or not helpful. So prison staff, I've heard prison staff refer to people with drug addiction as cockroaches who steal oxygen. And other prison staff have said these are exactly the people we need to help, and we should be helping them. Primary care staff, they may not know much about substance misuse, and they might be a bit wary of it, and they don't really want to get involved. So it might be difficult, or there might be some of them who actually want to develop an interest. Substance misuse clinical staff, again, they generally obviously have a better attitude, but you still get some people who are a bit stuck in previous ways of working in prisons when things were a bit different. When before these present guidelines, a few years ago, there used to be regimes for people having to come off methadone if they're in a certain length of time, and so on. There may be some psychosocial staff which don't like clinical staff, but generally I've found that the psychosocial staff have been excellent where I've worked, and even though from different organisations, they really complement the clinical substance misuse care. The organisations in which we work, we may feel supportive. We may think, oh yes, there's people we can go to, there's backup, there's resources we can use, there's ongoing personal development and that. Or we might be in organisations where we might be the person who actually knows the most about substance misuse, or the next person is quite a long way away. So that can be quite difficult. We might feel supported in what we do in terms of time and effort, or we might feel actually people don't really understand the pressures, especially if we're in primary care as well. So if you're a GP in the primary care system doing substance misuse work, you might find the head of let's say primary care, of healthcare, isn't really interested in methadone and may not even agree with people being on methadone, and so that can be quite tricky. And there may be legacies from the past of, well, we've never done it like this before, or we don't do it like that, or we tried that before and it didn't work, and those sort of issues which we can hear. And then there's the prisoners, stroke patients. The patients in prison, they're the same as the ones outside, I found, because they're just like, they come and go, and the same people see in community service and general practice I've seen in prison as I've seen when I was a GP and working in community services as well, and in the inpatient units. So they're not different, they're just in a different setting, and that's interesting. And they have their own beliefs and culture about what's going to happen to them, what treatment they're going to get. They might have negative aspirations, negative expectations, perhaps because of the way they've been treated before, or they may have heard good things and say, oh yes, so they've come to prison to actually get good treatment, which often happens. You get people saying that, especially alcohol people actually. But in terms of drugs, yeah, people often come to get stabilised, and etc. And all that sounds bizarre. That does happen. So they'll have expectations. We may or may not meet their expectations, but they'll be there. And then there are ourselves and our own issues and past, and how risk averse we are, and how much we feel we understand the substance misuse treatment, how confident we are in that, our training, our experience is a huge thing. What's that been our experience before? Have we been intimidated? Have we been felt uncomfortable? Have we felt unsupported? Or have we felt actually we're making a big difference here and it's really worth doing? So people are really, really important. What about the problems? Third P, what problems specifically to prison do we see? Well, substances, the types and amounts available. The amounts available are generally obviously a lot less, but a lot more expensive. And of course, spice is the biggest thing at the moment. The spice it'll be in different areas, be regional issues about what's on the horizon. But spice is very important, and then you get the usual Subutex, bit of heroin, benzos are a big thing. Then you get the pregabalin and the mirtazapines and all those sorts of things that are traded around, and the codeines. So it's a particular environment, and the interesting thing is that the things that trade around often have been prescribed to other people, as we know, and been diverted. So that's another issue in prison, which for people who do primary care work, that's a huge thing, which is another seminar altogether. Problems, devising guidelines that are based, they're guideline based, they're standard operating procedures. So that can be an issue if you're working cross-organisationally, because where I work, there are several organisations working into substance misuse in the northeast prisons, and sometimes we can just have different ideas and different governances and different ways of doing it, and I think that can certainly be a problem. It can make producing standard operating procedures across the partnership long-winded and tricky sometimes, but you can do it. But they are needed, especially across partnerships, because otherwise the things that are likely to go wrong if people aren't singing from the same hymn sheet, as it were. And then implementing those, very important. Again, if you're working with different partner organisations and they've got different management structures, that can be quite tricky. And then the prison regime itself, you know, when people are locked, unlocked, whether there's an officer available to bring people to you, or there's an officer around if you get into trouble, the availability of monitoring at night through the doors and all those sorts of things, lockdowns, staff meetings, they can all disrupt clinics. People not being brought, people not being on lists. The list is endless, the things that can happen in a prison to stop you actually seeing people and helping people. I think those of us working in prisons will recognise that. And then working with all the other people involved, things can get a bit, shall we say, difficult sometimes. There's stresses, people are pushed, people are harassed, and it ends up you can take it out on each other when really it's a system issue. It becomes personal, but it shouldn't be, and that can be a great problem, and that can be demoralising as well. And then the interface with the community services, very interesting. So what information do we get when people come into prison about, for example, GP medications? How long does that take to come? How do we find out about when they've had their last methadone and what dose it is? I found that ringing the chemists is excellent, as long as the best way to do it is to ring the chemist. I've got Joe Bloggs here, he's telling me he's on 60 mils of methadone and they last had a supervised dose 2 days ago. And if you say it like that, people generally are very forthcoming. If you just rung up and saying, is Joe Bloggs on methadone, then they say, oh, we'll have to ring you back, you know, and all the rest of it because of data protection. But thankfully, pharmacists have been very helpful if you ask them the right questions. And they also give you useful information as well. So community services, sometimes you need to talk to the community drug and alcohol service that people are with. It's generally pharmacists, though, from the prescribing point of view. I would also just mention at that point coroners in the community. In prison, and this will be varying in different prisons, people are very wary of coroners because deaths in custody are very focused upon, the spotlights on them. You're called up to coroner's cases, coroner's inquests. For some reason, there seems to be more spotlight than them on death in custody than in the community, and there are reasons for that. That's another issue. We have 24-hour care, which is a challenge. But on the other hand, where does the patient's own responsibility come into that? So people can feel under pressure because they want to be risk averse. They don't want anything to happen to the prisoner. Sometimes risk aversion, though, can actually be a bit misplaced because it might be less risky to actually treat the patient properly rather than to withhold treatment, and that's another issue as well. That's why it's so important to stabilise people properly, and generally that's much less risky. It's less risky to be on an opiate substitute script rather than to not to be on one if you've got an opiate problem. So the coroner looms large in many prisons, and then that the issue of punitive approach to treatment is a big one as well. That can be a legacy from previous regimes and previous guidance in the past. You know, if someone's using on top of methadone or whatever, they should be taken off their script, which, you know, is still an idea in some places, and that can be really difficult. And Whereas we know, and looking at the guidelines, you know, and Jake will be talking about this, it's a question of actually getting people stable. But then you've got to balance the risk of, have they used a lot of spice, how often they're using it, and all the rest of it. And so that's quite a difficult issue, especially if you've got looking over your shoulder at the coroner, because sometimes you're damned if you do, and you're damned if you don't sometimes. So those are all lots of problems and issues. What about suggestions and solutions? I'll offer some. I think, first of all, it's up to us to change the culture. And I think we often need to start with ourselves, need to look at ourselves, you know, where are we coming from? You know, do we understand the guidelines? Do we understand the spirit behind them? Do you try and understand where other people are coming from? What the past has been, things that have tried, try and listen to them, but also listen to ourselves and thinking, are we still a bit punitive? You know, we're annoyed when people that use on top or become intoxicated or tell us a lie even, which does sometimes happen. So, you know, that's quite important. It sometimes can trigger things in us that we need to be aware of, okay, that will stop people getting proper treatment. But it can be personally costly and uncomfortable. I know when I started where I was here, it's hard to go against the flow where people are saying, oh, you know, stop methadone, do this and that. But it can be extremely rewarding, and that's why I do drug and alcohol work. That's why I do substance misuse work, because you can see people getting better very quickly, and it's a good thing to do. And I think we've got to lead in it. We've got to be leaders. If we're prescribing in particular, for all of us, it's our responsibility to do things properly. It's our responsibility to see patients get the best treatment that we can provide, equivalent and often better than the community. And how I would sum that up is we need to demonstrate competent compassion in all our interactions. So that's even with patients and other staff. So we need to be competent, but people need us to be competent. Patients do, they want us to know what we're doing. We need to know what we're doing, otherwise it's disaster. But we need to be compassionate. We need to understand where people are coming from, that's patients and staff. And we need to listen to them, and we need to give them a hearing, and then we need to make decisions based on competence and compassion. If you do that, then you can do really well. We know therapeutic relationship is probably one of the most important things in people getting better. And for me, competent compassion sums that up. If you don't remember anything else from this, remember competent compassion. And I think that's going to lead to effective engagement and better outcomes for everyone, as patients and staff and ourselves. And finally, I would leave us with this. You know, cultural and organisational issues will melt away if we do this. Well, perhaps not. Perhaps they won't just melt away. It can be a slog, but I would say it's definitely a vision worth having. Let's give really good treatment, and let's see the great results that we'll get through that. Thanks very much.
Unmuted.
Thanks very much, Josh. That was a fantastic start to our session. It's generated a lot of questions. And before we move on to our next presenter, we're going to ask the audience another question. And so you've done one already, so you know how this works. So our next question should appear on your screen now. Do you feel restricted in your ability to offer long-term stabilisation on methadone buprenorphine to patients? And I can see that you're all voting. You're still voting. The votes are still coming in. Okay, I think we're there. We'll close that question now, and we're about to give you the results of that question. So it looks like 42% have said they do feel restricted in your ability to offer long-term stabilisation. 27% are saying they don't, and 32% are saying they don't work in a secure environment. So again, quite a sizable number of you feeling restricted. Having said that, it's nice to see that there's a good healthy chunk of you who are feeling they're able to offer long-term stabilisation as well. Okay, so I'm going to move on to our second presentation of the night, and I'm really pleased to introduce Jake Hard, Dr. Jake Hard, who is working in Her Majesty's Prison Eastwood Park, and he's also chair of the RCGP Secure Environments Group. And Jake is going to talk to us about stabilisation and assisted withdrawal. So over to you, Jake. Hi, Jake. Are you able to hear us?
There we go. Sorry, I thought I'd unmuted myself. I hadn't. It's the classic mistake. Sorry about that. I hope you can hear me now.
Yes, we can. Thank you, Jake.
Lovely. Thank you very much, Kate, and thank you very much, Joss, for your interesting talking. I wanted to just reflect a little bit about my background experience. I've had about 12 years of experience of working both in the prison setting and in wider community addiction settings. But also, and really sort of running through the rest of the presentation, just bring out some of my role as experience as an expert witness, many clinical negligence cases. I work as a clinical reviewer assisting the PPO with their investigation of deaths in custody. Obviously, those often lead into the coroner's inquests. I've also assisted coroners with their inquests, and I work as an associate advisor to the PHSO. So I'm hoping to bring out some of the risks and issues which will be familiar to all of you, whether you're working in a secure environment or not. Obviously, the main thrust of the talk will be around what we do in the prison setting, but I've learned my craft across both sides of the wall, if you like. Let's see if I can get this to move forwards. Okay, it's not moving forwards.
Jake, would you like?
Okay, there we go. So, yeah, there we are. So we've got the objectives there. I'm going to give you a brief introduction, which I've done. Talk briefly about stabilisation and opioid substitution. Also discuss a little bit about toxicity and treatment, and a little bit around the assisted withdrawal piece. So the guidance that I'll be referring to primarily will be the clinical management of drug dependence in the adult prison setting from 2006 and the new updated 2017 guidance, drug misuse and dependence UK guidelines. But also just to reflect that, of course, these are based also on the NICE guideline, which I'll touch on in a moment. So both of those pieces of guidance that I've just shown you there do refer to detoxification in the prison setting. I'm not going to read out what is written on the slide there to reiterate it, but that's about the length and breadth of what they describe are being the sort of salient features of detoxing people in the prison setting. It does refer there to people in prison should have the same treatment options for opioid detoxification. I think, just picking up on Joss's point about things being better in the prison, the current terminology is that we would say that it would be at least equivalent to what's available in the wider community. And I agree that often access means that sometimes we are able to provide that. So moving on to the next slide. So back in 2006, IDTS was really the primary piece of guidance that, and the clinical management of drug dependence in the adult setting was really the main piece of guidance that brought into being the approach to stabilising people on methadone and indeed Subutex, which I'll come back to later on. So it really was a very groundbreaking piece of guidance at the time, because prior to that there wasn't really any structured piece of guidance setting out how people should be provided treatment at the early outset in opioid withdrawal. So the guidance really spoke about stabilisation on a licensed opiate substitution medication. We're 12 years later and we still have really only two of those things, methadone and buprenorphine. But it suggested at that stage that stabilisation took about 5 days to take place. And equally in the Orange Book, it talked about the same principle. So the two pieces of guidance actually marry up quite nicely in that respect. So I'm quite reassured by the UK, the Orange Book, if you like, that it very much mirrors what's been said in the original guidance from the Department of Health. The mantra, which I'm sure you've heard, and if you haven't, tattoo it on the back of your hand if you're prescribing to people who have who are going to be prescribed to: start low and go slow. I cannot emphasize enough the importance of being clinically and professionally curious about the history that you're being provided by your patient. If there's anything that makes you suspicious that what you're being told doesn't ring true, it doesn't match with the urine drug testing, or the CAL scores don't quite match what you're being told, then always counter that by taking into account your prescribing and start lower, go slower, whichever way you want to do it, or consider whether you're prescribing other things in combination, or a little bit of everything there. And certainly relaying your concern to colleagues about somebody's history or the fact they might need to be observed are important salient features within that. So, as I said, stabilisation should take about 5 days to start with, but that really depends on a number of factors. I think we might be going backwards, so I'm just going to roll forwards. Apologies for that. So the things that often stick out in my mind are, it's worth asking about previous methadone or buprenorphine prescriptions and what dose they stabilized on. That can sometimes be a very useful way of assessing. Clearly, somebody who's never had any form of opiate substitution is going to be likely to be at higher risk, bearing in mind, as it states in the UK guidelines, you know, there have been deaths with doses of methadone as low as 20 milligrams, so be extra careful. And I also like to know whether there's been, even if that's been illicit use, that can be quite telltale. That will give you an indication whether the patient themselves is a bit cautious about the medication. Coming back to looking at symptoms of withdrawal, as we will do in a moment, I always ask about recent use of illicit methadone or buprenorphine, because that can really shift the clinical picture that you're seeing. And that's the sort of the slide that I'm going to move on to next is around the subjective versus the objective signs of opiate withdrawal. So I'm sure you will recognize a CAL score. I've highlighted this one to really draw out the difference between those symptoms and those symptoms that are objectively reported, that are subjectively reported by the patient. So they will be able to tell you whether they have difficulty sitting still, but you will be able to observe if there is frequent shifting or extra movements, or if they're unable to sit still for a few seconds. So I would always encourage you to look at the orange highlighted pieces of questions and sort of objective measurements in order to calculate your own CAL scores, or justify your own prescribing, or the level that you're going to with regards to that patient, the amount of withdrawal that you're seeing on the basis of some of these more objective signs. I mean, I think it's quite interesting to note that you can actually score about 10 on a CAL score with purely subjective questions, which is high enough to warrant a prescription. But I would counsel you that obviously you need to be looking for some of those more objective features so that you're making yourself, if you like, coroner compliant. So just a reminder, some of those objective signs which can't be faked really: dilated pupils, runny nose, yawning, goose flesh. Don't be afraid to actually get up close to the patient and observe them. Don't just take a history. What about those patients that there is an overlap with alcohol withdrawal? Because quite frequently our patients do come in having a combination of the two, or at least reporting a combination of the two. And so I would often it's very difficult. COW scores and CUR scores are not designed to be used in conjunction, but we're left with those tools to use. So try and discriminate between those things. And you'll see that I've put some O's next to those things which are more likely to be related to opiate withdrawal, and I've put some of A and O next to those things which might be seen equally. And there are some things which are probably more likely to be seen in alcohol withdrawal on the right-hand side of that side. So particularly sweating and tremor. Obviously, the coarse tremor of alcohol withdrawal is different to that of a fine tremor in opiate withdrawal. So documenting these things are really key. I'm not going to go into CUR-B scales. I would argue, is there a case to consider the use of breath alcohol machines? Joss might have a view on that based on his experience of working in inpatient settings. I know they've been useful in some of the criminal justice settings I've worked in. Okay, so stabilisation. I'm going to move on to the sort of prescribing principles of stabilisation. As I've mentioned, start low, go slow. Gradual dose induction in increments of 5 to 10 milligrams of methadone is the starting point. Obviously, consumption should be supervised. There should be regular monitoring for drowsiness, and withholding the dose if there is sedation. If the patient looks sedated or the staff feel that the patient looks sedated, withhold the dose. The worst thing that happens is they will be a bit grumpy with you, and they may go into some withdrawal, which at least gives you a justification for either giving them the dose of medication or adjusting the regime. Of course, as I've mentioned, it may be other evidence of other withdrawals that may be useful to start thinking about, whether it's later down the line, such as the benzodiazepines, or whether the alcohol side of their complaint has not been addressed adequately. Dose titration in prison should be really probably no more than 30 to 50 milligrams. And I'll just advise you, I'm talking about those patients that are coming in having not been on a community prescription. Obviously, those that come in on a valid prescription may be on higher doses. So because of the reduced availability of opiates in the prison, a dose of 30 to 50 milligrams is usually adequate. Occasionally we will go higher than that, 55 or 60 milligrams, but I've yet to be convinced that it is required. A dose higher than 50 or 60 milligrams is frequently required in somebody, no matter how severe their heroin or opiate dependence before coming in. So methadone toxicity, interestingly, occurs about 3 to 10 days into treatment. So it's not something that you should assume is going to happen with your first couple of doses. It's got to reach a peak plasma concentration within 2 to 4 hours because of your metabolism, but in fact the variable half-life of it from individual to individual is much longer than that, and therefore you can accumulate doses quite over consecutive days, depending on how rapidly you're titrating it, and hence the advice that you should be 5 to 10 milligrams at a time. So again, regular monitoring for drowsiness, withholding the dose, and withholding other hypnosedative medications if you do see it. And don't be afraid to give naloxone if you think about it. And if you are giving naloxone, don't be afraid to consider phoning an ambulance and arranging for them to be admitted to hospital. Okay, so stabilization with buprenorphine. Effectively, depending on how opiate dependent they are, buprenorphine can be slightly trickier. If they've had recent opiates, you're going to precipitate opiate withdrawal. Again, if their subjective view is that they're in withdrawal but they're actually not, then you're more likely to precipitate withdrawal. So again, the higher the level of their COW score, the less chance you are going to have to precipitate or worsen their withdrawal symptoms, the greater the chance you're likely to make them feel more comfortable. So commencing at a dose of 2 to 4 milligrams on day 1, as I'm sure you were aware, you can titrate quite quickly with buprenorphine relative to methadone, and so you can go up to 8 milligrams on day 2, and regularly in the community we used to go straight up to 16 milligrams to try and get that blockade effect. But in the prison setting, a usual dose of 12 to 16 milligrams is a sort of a reasonable level of requirement for buprenorphine, and rarely would we require more than this to stabilize somebody's opiate problem. Okay, so again, as I've mentioned, precipitation of withdrawal, it is still an opiate, so you do still need to monitor for drowsiness. It does still have respiratory depression as a potential effect. So again, if it's in conjunction with other hypnosedative medications, you want to be conscious of that interaction. Obviously, we're all probably well aware of the risk of diversion with the tablet, so if there's any issues around that, then obviously you may need to consider switching the patient from that treatment. Okay, so assisted withdrawal, as it states there, should be considered in combination with a view of a combination of factors, including the severity of the patient's dependence, their wishes, the opinions of the clinicians involved, and the timing and length of their sentence. I'd like to think that actually we've moved to a slightly more complex position now, where we can take into account some more useful information. I mean, if we look at the equivalence piece, certainly it can take many years in some of my patients to have reached a level where they're ready to come off their methadone or their Subutex for management of their opiate problems. So why shouldn't we be applying the same principle within the prison setting? I think the days that they kind of, well, you're in for a sentence more than 12 weeks, therefore we're going to detox you, really should be over and are not considered to be equivalent to the wider community. Of course, that does need engagement with the substance misuse services, so that we can look at ways of assisting people with making the decision, but often people do require a period of stabilisation, much longer than the sort of expected 12 weeks to reach that position. We can't expect them, simply because they've been incarcerated, to reach a view, okay, well, I'll never use drugs again if I just get those 12 weeks of treatment. So thinking in slightly longer terms, I would add to the thoughts about severity and patient choice, add in some other thoughts that I've come to conclude are quite useful. What about the previous history of overdose on release? If it's there, then we should be looking more at stabilising people throughout their treatment in prison. Those people, I find, are also the ones that are often illicitly misusing in the prison setting and causing all sorts of chaos, not only for themselves, but often for other people in terms of bullying and violence. So sometimes engaging with them more heavily and getting them on a form of treatment can actually try and stabilise the situation and avoid some of those problems. And I would also be minded of those people with co-occurring medical issues, so people that are perhaps having treatment for hepatitis C or TB or have significant mental health problems. Be wary of simply just offering them or providing them with a detox or assisted withdrawal too soon, because you sometimes may find their mental health issues unravel. So key considerations for assisted withdrawal with methadone: generally speaking, a reduction of 5 milligrams every 1 to 2 weeks. Make sure you continue to follow up and reassess the patient. Make sure that they're continually engaged with that psychosocial support. And as I've mentioned, consider those other issues that they may have along the way, and don't be afraid to pause for thought with that reduction. Assisted withdrawal with buprenorphine, roughly speaking, 2 milligrams per week is considered reasonable. Same rules apply: follow up and engagement, and consider those co-occurring medical issues before simply taking them off treatment. And that concludes my talk. Sorry, it's a bit of a whistle-stop tour.
That's fantastic. Thank you so much, Jake. Well, you managed to do a lot in a short period of time. Thank you. We're going to launch another question before we introduce the final poll. And can I also say, at the end of this webinar, you'll all be sent an evaluation sheet. It's really only 6 questions long. It shouldn't take long, but we'd really like some feedback. It should appear on your screen once the webinar finishes. And we're also interested in hearing from you if you've got examples of good practice or might be interested in joining some sort of informal network around these topics. So please fill that in at the end. Okay, we're going to move on to our next poll. Is retox onto methadone or buprenorphine available to prisoners at your establishment? Okay, our results are coming in. Okay, I will close that now. I think most of you have voted and you should be able to see the results there. So about half of you say that it is. 16% say no. Given that 34% don't work in secure environment, that's pretty good. It looks like for the vast majority of you, retox is available if you're working in the prison. Although we would like to see that no go down to 0, I'm sure. So I would like to introduce our third and final presenter. Tamara Healey is a non-medical prescriber working at Eastwood Park Prison, and she is going to talk to us about retoxification. So over to you, Tamara.
Hi all. It's lovely to speak to you this evening. So yeah, as Kate said, my name's Tamara. I'm a nurse and I work in a southwest female prison. I have been there for about 12 years now. So I went as soon as I qualified as a mental health nurse back in 2007. Yeah, well, as I said, went straight to Eastwood Park, specialised in substance misuse straight away. Prior to that, I've worked sort of within mental health, and I've also worked at community units. So I've worked in sort of detox and stabilisation units in Cheltenham, so not far from myself. So I'm here today to talk about retox. If I can get my screen to work. There we go. And this is what I'm going to be looking at. So I'm going to look at some statistics in a minute. I just wanted to show you a few statistics just to put things into perspective, really. I'm going to look at sort of retox, who and when, what retox options are available. I wanted to talk a little bit about naloxone, and then, yeah, so just offering that sort of 360 service and just about an NMP and NMPs of specialist interest. So here's some prison statistics. So as of 2018, as you can see, there's approximately 83,000 people in prisons within the UK. So male prisons, that's 79,000. The female prisons, that's 4,000. Of this, 50% of males have, this is approximately, 50% of males have drug addiction, and it's higher in females of approximately 70%. The next figure is very approximate because there's no definite for this. But some interesting stuff I found out when researching this was that 8% of people that go into prison acquire an addiction whilst in prison. So that's illicit and prescribed medication. A few more statistics, sorry. So research shows that there's a 7-fold increase in overdose deaths in the first 2 weeks post-release, and this has increased in the last 4 years. Drug-related deaths are now at their highest since 1993. So 1993 is when these statistics started to be collected. So that's why we have that date on there. Here's another one. So from a study in 2017, there were 1,033 deaths in the first 12 weeks post-release. 59% of those were in the first 12 weeks, but 76% were in the first 2 weeks, and that was overdose. So, you know, we're looking at quite high figures there. So I'm here today to discuss retox. I'm very much of the opinion that prison is a chance to get it right and be able to offer a safe and secure environment for people we care for. I also am very much of the opinion that we need to offer a really good follow-on care. Because as I'm sure you're all aware, we still have responsibility for our patients for a period of time post-release. So I think it's really important that we get it right when they're with us. As you can see on this screen then, so this is who we're looking at for retox. So retox is basically looking at going onto a medication before release when someone has already detoxed in a custodial setting. So whether or not that detox is enforced or through choice, we have patients that will come to us and say, I'm anxious about getting out. I'm thinking about using. Oh, sorry, bear with me. Just lost my microphone then. I'm anxious about getting out. I'm worried about using. I saw someone a few weeks ago who was having constant sort of nightmares about it. Just really, really anxious. So we where I work, we like to look at sort of each person as an individual, and we do offer retox, as I've said. So statistics show those that most at risk are the injecting drug population, patients who have a history of overdose post-release, your polydrug users. I also think that we need to pay attention to people who historically smoke, and patients who have developed an illicit habit whilst in custody. As mentioned before, you know, that's increasing. The amount of illicit drugs in prison is increasing. So to ensure stability and tolerance, retox should be a minimum of 1 week prior to release. Buprenorphine can be titrated faster than methadone, and 4 days prior to release could be an option. So prior to agreeing to retox, you need to offer discussion and support to your patients. So if a prisoner reports a concern that they feel vulnerable, there's a couple of things you need to do. So we're lucky at Eastwood Park where I work, because we have substance misuse clinic appointments where they'll see myself or another non-medical prescriber. So we tend to see them, talk about best options. I also, if I get we have tasks, because we use System 1 where I work, so we'll have a task, and if someone's asking for retox, I will ask for them to have enhanced psychosocial support for a period of time. And also, we have a continuing care team, which is a team that looks at community. So obviously, if you're going to retox someone, you need to have a community prescriber. And also they need to have continued psychosocial support in the community, because as we all know, it's not just about having the medication, it's about having that support alongside that medication. Also, another thing that I make sure is in place is that they've had their naloxone training. Naloxone is really important, and I will talk a little bit about that in a moment. When they come to see me for an appointment, the first option that I usually discuss, I'm not going to say everybody, but I usually discuss naltrexone. Unfortunately, naltrexone is not a favourite, and there's a bit of bad press, I would say, about naltrexone. I think you'll get people talking to each other, and if one person's had a headache from it, then the other person will have a headache. And also, a lot of people want to go out and drink, and it does affect how alcohol works for you. So a lot of people don't like to use naltrexone. So part of the process for retox, following that discussion, if they decline naltrexone, we then take them to a multidisciplinary team meeting, which is an MDT, and we take them there so we have a meeting once a week where we take the patient and we discuss kind of their worries, what support they've had, how they're engaging. We look at their injecting drug history. We look at their history of opiate dependence. We look to see whether or not they've got a history of non-fatal overdose. We look to see if they've previously been released from prison with or without an opiate substitute. We check to see if they're engaging. Engaging is really important. Again, like I said before, we check to see if they've got a community prescriber, and we look to see if they've been illicitly using. As mentioned before, we increase psychosocial support, and make sure that psychosocial support can continue outside. So once we've discussed at the MDT meeting and it's been agreed that your patient can retox, these are sort of the options that we would look at. So methadone would always be our first line. So for our opiate naive patients, we tend to do a slow titration to 20 mils of methadone. For patients with a confirmed illicit use problem, I would sit down with the patient and I would look at what's historically worked for them. As Jake said, and Joss, you need to look at what's helped in the past. What's kept them abstinent from drugs in the past. It's about that sort of keeping them safe when they go out the door. Buprenorphine, as written, is the safer option. You can retox onto buprenorphine a lot quicker than methadone. So for like Jake mentioned in his last slide, I would look at retoxing someone between 12 and 16 milligrams, because you really want that blocking dose. So I've seen it work really well in the past and patients do go out there and they really do stay off heroin. So I think buprenorphine is a really good option. So there's a few examples you can see on the screen of how we retox where I work. So slower, there's a slower one, you can do the 2 milligrams BD, 4 milligrams BD, 8 milligrams BD, then to 16, or for confirmed illicit use, you can go 4, 8, 16. We had someone who was being released a few weeks ago, and she got tagged, which is basically where we didn't know she was going, and at the last minute they said she could, and we've been having discussions about how sort of anxious she was about release. Hadn't long come off a methadone script, but she did have quite a long sentence, but we managed to get her up to 16 milligrams in the weekend. So, you know, and she obviously felt much safer with that, and we had really good psychosocial support set up for her when she left. As I said, I just wanted to talk a little bit about naloxone. So naloxone is a non-controlled drug, and it reverses the effects of overdose. So in 2012, the Advisory Council on Misuse of Drugs recommended that take-home naloxone be more widely available. We did a trial of it at Eastwood Park back then, and it worked really well. We now do it for everybody that comes into prison that goes on to our substance misuse wing, and we have a really good uptake. We've had knowledge sort of back saying that it has saved lives, the naloxone that we've trained our women with. So as you know, I think it's something that I think everyone should look at. We also look at naloxone when our patients don't have a community prescriber. So as much as I've said about retox being a really good option, it's unfortunately still in this day and age is not an option for everybody, because there are some patients that, because of numerous issues, they can't get a prescriber outside. We've got one area in the country where there is just no prescribers, and we send patients to, so we always ensure that naloxone is an option. So offering a 360 service, I feel it's really important for patients to feel safe throughout their prison journey. We need to offer a holistic approach, so we need to offer best practice wherever we can, and we need to make sure our patients feel valued, safe and listened to. They're not just a number. They are individuals. Yes, they're in prison, but they still need to be really valued, and we need to listen to them. We have to remember that patients in prison are entitled to the same provisions offered in the community, and for these reasons, a retox needs to be a multi-agency approach, and good communication is a must. So, as an MP working in the prison, I feel confident and comfortable to use the people around me. I consider retox sort of a best option, a safest option. I think it's really important to work with everyone around you, and if nothing else, I feel it's really important not to give our patients false hope when discussing retox. As I said before, we can't offer it to everybody, but we try to offer it to most if they want it. We don't have massive numbers at Eastwood Park where I work of women that want to retox, and that's mainly down to the fact that until recently we used to enforce a detox on patients of serving 6-month sentence or longer, but we don't do that anymore. So that's a really new thing, and I'm hoping with that in place now that we will see sort of lower. This is a hope for me. I'm hoping that we will see less illicit use, and obviously we'll see less retox because we won't be detoxing as many patients as we did before. So that's it from me, and thank you everybody. Thanks, Kate.
Yeah, thank you, Tamara. Great talk. And this does lead us into questions. Before we have questions, we're just going to do one last poll. And we're going to ask you whether naloxone is available to prisoners leaving the secure environment you work in. And we're getting the answers in. Okay, I think we'll close the poll here. And you can see there that 47% of you answered yes to that question. 22% answered no, with 31% not working in secure environments. So I think that's promising, but we would love to see that 22% right down to zero. Okay, so we now have time. I'm aware we're getting very close to 8 o'clock now, but we're going to have time for a couple of questions. We understand if people need to leave, but we won't go on for much more than about 5 minutes here. And so I'm going to go straight into a question. Someone looks like someone from Scotland. And can I ask Jake, could you answer this question? It says the Scottish Prison Inspectorate were concerned for patients on under 60 mils of methadone as it conflicted with the Orange Book. Is this the advice offered in England? Jake, you may need to unmute yourself. Joss.
Yeah, should I just
give a go?
Jake...
Yeah.
Yeah, it's a very interesting question indeed. Very quickly, you'll find people saying that 60 to 120 mils of methadone is the therapeutic dose, but I don't think there's anything magic about that. I've found in prisons, people are fine on about half the doses in the community because there's just not the same amount of drugs around. So, so people may well need more 60 or more in prison, and we shouldn't deny that. It should be an individual basis. But just because people aren't on 60 mil doesn't mean to say they're not on an effective dose. And many patients will actually say, I don't want to go above 30 or 40 anyway, and I'm fine. So I would be guided by the individual patient and just realize that in prisons, methadone dosing is less than it is in the community in general.
Okay, so and I would totally support that. I think there's no justification for increasing everybody towards 60 mils of methadone, and the guidance doesn't support that view.
Okay, thank you very much. And I've got another question here, which is when prisoners are using spice, somebody has noticed that their OST is reduced and then they are detoxed. Do you agree with this? Could I put that one? Could I ask you to answer that, Jake?
Okay, so I think there's always got to be a patient safety element to this, and taking the punitive approach and simply stopping and detoxing people when there is use of whether illicit substances, whether it's illicit prescribed substances or properly illicit substances like spice, doesn't really work. I think some of the things that Joss referred to about engagement are probably the first course of action that you need to take. If there is persistent misuse, then of course you're going to need to consider the overall level prescribing, but using the script of methadone or buprenorphine as a tool of punishment is completely unacceptable and will not be viewed from a clinical negligence point of view as being a good outcome for you. Absolutely right. Agree with that.
Thank you. And I think we've got time for one final question, which is why is methadone so often the first option when in a prison setting, when buprenorphine can be the safest and quickest option available? And I think they're talking there about both retox and induction. And
I can answer that if you like.
Oh yes, please. Yep.
I think methadone, where I've certainly worked, methadone has always been the sort of the first choice. I think we've got quite an issue with diversion of buprenorphine because it's a tablet. Although we crush it, we have a sort of a high issue with diversion and not with methadone. So from our sort of from us looking at it from that point of view, I think that's one of the reasons why we always tend to look at methadone first. Jake and Joss might have another, I think, something to add to that, but it's about the diversion.
Okay, would anyone else like to add to that?
I think in general, I think if we're going to have equivalent care, we ought to offer either. And some people do better on one, some people do better on another. I totally agree that diversion is more of an issue with normal buprenorphine, although the new the new wafers that melt are offering hope in that regard. So there's a cost issue there though, but ideally we should offer either.
Yeah, so I'm in agreement with that. I think diversion is a problem. We do see diversion in the community, in quite significant levels of diversion in the community. It often is driving the illicit trade inside prisons. So people are coming out non-opiate dependent, trying to service debts and trying to acquire prescriptions of buprenorphine in the community so that they can send it back in or take it back in with them. So it's certainly something to be alert to if you're having somebody in the community who's presenting as potentially or possibly not truly opiate dependent.
Okay, thanks everybody. And before we go, I would just like to mention that we have another webinar coming up. If you've enjoyed this, we have another webinar coming up in January, on the 21st of January. That is for our SMMGP premium members, and it's on titration of OST in prisons. I'm going to send you details of how to join SMMGP premium membership, which is a paid for membership, and you get a minimum of 15 hours CPD a year in webinars and précis of research. And can I also just mention that on the 31st of January, there is a Health and Justice Summit, a 2-day conference organised by the Secure Environments Group, which Jake is the chair of. That's the RCGP and Secure Environments Group, and that is in Liverpool. So if you're not booked on, please book on, and there's details of that on the SMMGP website too. I'm going to wrap it up now. So I'd like to thank all the presenters for fantastic talks. I'd like to thank everybody for the questions. We haven't managed to get through them all. We may be able to contact you with some answers to some of your questions for those who haven't had their questions answered. And I wish everybody a good night, and we'll send on details of how to access this webinar again in the next few days. Okay, thanks everybody.
Thank you.
Thank you.